Good afternoon, everybody, and welcome to this second of the taster sessions that we are delivering as part of the UEC Recovery Universal Support Offer. Today's taster session is all about using data to drive improvement, and we have Chris Green joining us from the ESIS team to deliver today's session. Just a few technical things to explain to you all before we kick off. The session today will be recorded and we'll be able to access the recording after the event. We'll also be sharing the transcription from today's recording, so if anybody has any accessibility issues, you will have access to the transcription. There is a Q&A function available today, so I would actively encourage people to ask any questions. We've got a short amount of time at the end of the presentation to pose some questions directly to Chris. However, for any questions we don't get to ask live today, we will be doing a written update of those questions that will be going out to delegates post the event. So, Chris Green, who is the Head of Informatics for the Emergency Care Improvement Support team, is going to be delivering today's session. I've worked with Chris for quite some time now and have definitely heard some fantastic presentations that he's done around data before. As a person that will hold my hands up and say don't necessarily find data that awe-inspiring, Chris certainly does make it that way, and I would go as far as to say he quite makes it fun as well, which is great. So without further ado, I will hand over to my colleague Chris to take you through today's presentation.
Thanks very much, Lisa, and good afternoon, everybody. It's lovely to see so many people on the call. Thank you for that glowing reference, Lisa, as well. So I'll try to live up to expectations. Well, as I said, good afternoon. I'm conscious that we've only got around about 50 minutes to go through an awful lot of different pieces of data and some other kind of concepts around measurement for improvement. So unfortunately, we are going to be going through this at quite a rapid pace. However, what I'm hoping to do is to give you a taster as to kind of what is going to be in the longer sessions, which are going to be delivered in a couple of weeks' time. So what we're going to look at today are a number of different areas. We're going to look around UEC flow. We're going to look at MFI, SED it, see it, SAM it, SAP it, ECDS, ROAN, demand capacity, and if we have time, we're also going to have a look at an acronym dictionary, because if there is one thing that we know there are a phenomenal amount in the NHS, it is acronyms. And I first off want to start off by looking at why there is such a scrutiny around urgent emergency care, but there is also a scrutiny in one particular area of the pathway. Now, don't get me wrong, my professional career as a process mapper is absolutely flying, apart from my very rudimentary use of icons. So forgive me for my over simplistic view of an urgent emergency care pathway, but roughly speaking, we have different areas of a system, and the reason why I put this process map up there is because I want to talk about the fact that this is a system problem. This is not an acute provider problem. It's really important that we understand that, and some of the work that has historically been happening through ESIS and a number of other different teams through NHS England have been trying to support a system around urgent emergency care recovery. But we've got different areas within this particular process: primary care, 111, ED, SDEC, base wards and post-acute. But the reason why we've got such a scrutiny is where the data is available. And predominantly, the vast amount of data is available. Joe, if we could just go to the next one. The vast majority of the data is around the emergency department. So why the scrutiny is around emergency department? It is because that is where the vast amount of data is available. We also have data for other areas within the system, but you can see that we have loads of data around the emergency department, and we're going to go through those as we go through the session today. We do have a good amount, but less area of data around SDEC, same day emergency care. And as we go down that list, base wards, 999, 111, etc., we have less data available. So why is there a scrutiny so much placed on the acute and the emergency department? Primarily because that is where the vast amount of data is. And where you have data, you can start to challenge this. Now, there are other different areas that we will be focusing on, but what we're going to be trying to aim through the UEC recovery plan is to make this a much more uniform approach to the amount of data that is available across the urgent emergency care system. We're also going to be starting to touch on what is the role of an analyst. And to be honest with you, the term analyst or analytical services, or call it what you will, is a really, really generic term. The challenge that I see, and I've worked as an analyst across multiple different organisations across the NHS, ranging from pretty much every part as I just described. But the reason why I kind of talk about what the role of an analyst is because there is a big difference between someone who can handle data and someone who is an analyst. Now, I can get anybody to create a graph. Okay, that's not a problem at all. We all can use Excel to some form of proficiency, and we can all create a graph, whether you're a data person or not. But actually, there's a massive difference between being a data handler and an analyst. An analyst really uses the data to kind of create this narrative. But most importantly of all, and what we're going to be looking at in the later session, is how we bridge the gap from evidence to anecdote. Now, an analyst would historically stay in the sphere of evidence. They like what the data can prove, getting data from different sources, understanding the different varieties of data and where that is available from. But actually, what you also have is you have people who deal in anecdote, which is kind of clinical people and operational colleagues. Now, the two need to marry up between the evidence and the anecdote, because if you have only one of those, it's difficult to have a compelling narrative around what is going on. And if, for example, you wanted to write a business case to get more money around that you need more staffing, if you only have one of those particular areas, it is unlikely that business case will be granted, because you need to combine what we know with what we think and what we feel. Really understanding the good role of an analyst, understanding how they can work with clinical and operational colleagues is absolutely pivotal to making data for improvement and driving that improvement journey. And also, and I'm not too sure whether there are any analysts on the call, but I implore you, if you don't know your analyst, your information people within your organisation, please go and seek them out. They're probably in a dark cupboard somewhere, and they would welcome a little bit of daylight to come through the door. For you to go out and reach to them to kind of say, this is what I do, this is how I do it. All the things I've learned working with people like Lisa is understanding what happens on the shop floor, what happens on the patient's pathway, what are the terminology that are used as well, because then we can, once again, bridge that gap from the evidence to the anecdote. Next slide, please, Joe. So let's start off to have a look at data. And I know Lisa did mention around the fact that data isn't for everybody, and I absolutely get that. However, there does need to be some level of understanding around what is going on in your individual organisation. And what I'm really aware of is the fact that for years and years and years, organisations have sent a phenomenal wealth of data to NHS England, and historically NHS England have not done that much with it in terms of promoting back to organisations what we have noticed. And the thing that we as NHS England can do is provide a national context to some of the performance issues which are going on in your organisation. So what I'm going to be doing now is I'm going to be taking you through a series of different analytical products that are all available to you, and we will be sending all of these links out to everybody so that as we go through this journey together, we can make sure that everybody has access to the same thing, because it's really important that we understand what is available, where it is, and how we can get access to it. So the first dashboard that I'm just going to show you is called the SAPIT, which is the Summary Acute Provider Indicator Table. And as I talked about at the beginning of the presentation, we've kind of got these silo aspects of the organisations within an individual system. And there are an unbelievable amount of dashboards in NHS England and in different acute providers as well, and across the system, that are siloed dashboards. And what I mean by that is they will just have one element of a system in that particular dashboard. So if you want that data around population health, go to the population health dashboard. If you want data around 111, 999, you go to that dashboard. Discharge, you go to these siloed dashboards. The reason why I created this dashboard was to bring different elements of the system approach to one particular area. So what we can see there are different domains, and that is a common word that is used throughout almost all of the dashboards that I'm going to talk about. Yes, they will be part of a larger product, but contained within those products are areas of domains. So we can see, for example, there are multiple different domains here. On the top left, we start off with population health, move to 111, ambulance demand, hospital admitted care. But what is important to do is it's important, as I said, to put a national context to this. So for this particular organisation, if we said, and let's pick on 4-hour performance as an example, I don't necessarily just like to go there, but we say to this organisation, oh, you're currently just below 73% for your 4-hour performance. It doesn't really add any weight to it. It doesn't provide any context, because all we're saying is there are approximately 50 measures over here, and you are achieving a certain level in each of those measures. But actually what we want to do is we want to provide a different level of context to that, so that you can demonstrate whether you are performing particularly well in that in that particular measure, or if you are significantly struggling. Now, Theodore Roosevelt once said that the comparison is the thief of joy, and I really do kind of agree with that methodology, but sometimes it is important that we do compare ourselves with other organisations. The only thing I would say around this is you have to take comparison with a pinch of salt, because you can't directly compare yourself with all other hospitals in the NHS because of multiple things that are going on. So, for example, you could say, well, I work in Plymouth Hospital and I'm going to directly compare myself with Royal Liverpool as an example. Unless you know that the demographic makeup is exactly the same, the services that are offered the same, absolutely every component around those two hospitals is the same, you cannot directly compare and contrast. But that doesn't mean that you shouldn't start there as a starter for 10. If we just go on to the next slide, please, Joe. And what we can see from that is where we've got the individual measures that I just showed you about, where there are no national context to it. If we put it on a completely different keel and we put in all of the different ratings within here, each of the measures is shown where each of that performance fits within a national comparator. And what we can see from here is we can see different colours. We've got red, amber, light green and dark green. Red being the most challenged quartile in the country, then amber, then light green, and dark green being the least challenged. And I make no apologies about using the terminology about most challenged and least challenged. I think for too long we've used very negative language about bad performance, worst, things like that. If I was in an organisation who are significantly struggling, and I had an outside organisation coming and tell me that you are really badly performing, and that sort of demotivation is not appropriate. So I make no apologies around using that sort of terminology. But the reason why we put this RAG rating in is because we can then have a look across the whole system, and we can automatically and very easily identify the most challenged areas that we would like to focus on. So rather than having a look at, well, we need to have a look at 111, or we need to have a look at primary care, or wherever it is that we need to look at, we can quite quickly, within 30 seconds, once we've understood the dashboard and the data contained within it, but actually we can have a look at this dashboard and it automatically identify in red the areas where we are most significantly challenged. And in this particular organisation, the vast majority of the challenged areas are over on the right hand side, which is around outcome measures, significant amount of long stay patients and significant challenges around discharges. So I hope that's okay, but what we plan to do as we go through this session is talk you through some of the dashboards and products and services that we will be talking about in much more detail in the sessions in a couple of weeks' time. Could I have the next slide, please, Joe? An area where people have been looking at for a number of years is around measurement for improvement. The terms measurement for improvement are kind of intrinsically linked with another acronym which you may have heard about, which is called SPC, Statistical Process Control. And when I worked in an acute provider, it was a buzz phrase, SPC. You must SPC this, you must SPC that, without understanding the real fundamentals of what SPC actually is designed to do. And what it's designed to do, a measurement for improvement approach, is designed to measure specific measures linked to your objectives and aims. And I've just shown this demonstrated in two ways, and why you should move away from a standard line chart to move into a much more statistical process control focus. So over on the left-hand side, for this particular organisation, we've shown the number of ambulance handovers over 30 minutes that happen every single month since the midpoint of 2021. So we kind of made the cutoff at 2021 because that was when activity and performance levels went back to, quote, a normal level after the pandemic. Around about between June and August 2021 is where activity levels went to start to go up to a pre-pandemic level. So that's why I've kind of taken it from here. But what we can quite clearly see over on the left-hand side is that there was something happened at the latter stages of 2022, around about November time. Now, if you just used a standard line graph, you might kind of say, oh, well, look, that's been an improvement, but that's really impressive. But the benefit of using a measurement for improvement, an SPC approach, is it will apply some statistical relevance to the data that you are putting into these charts. And the chart on the right-hand side, once again, freely available as a template from the NHSE website. We can certainly provide those links to you as well. What we can see, once putting the data into a statistical process control model and putting down the fact that this particular organisation made a specific improvement around November 2022, we can see the impact that that improvement had. So it will automatically calculate what is within normal variation. So we've got the wiggly line, which is the data points. We've then got the dotted high and low confidence levels. But then what we can see is because we then implemented an improvement approach in the latter stage of 2022, we can see two things. One, it has statistically significantly gone down, but not only that, the margin for error has significantly reduced as well, because a lot of the times stuff goes up, stuff goes down, absolutely, but it is the volatility which creates a real problem around demand and capacity, which equally we're going to be talking about in a few minutes' time. But since the improvement came into place, it has reduced, and we have also reduced the level of margin for error. Thanks, Joe. Equally, something that NHS has done for an awfully long time is focusing on kind of relatively core measures. Now, I'm not saying that's not important. It's incredibly important to look at 4-hour performance, 12-hour performance, CAT2 response times, long stay patients, because they are intrinsically linked to clinical risk and patient harm. But we also need to understand some of the softer elements around the services that we A, have, and B, should provide in order to cope with the population health for our local population, our local catchment population. So with the SAPIT dashboard, we equally have some demographic data where we can understand. On the top left-hand side, we can have a look at the demographic makeup of our patients. So we can say, right, do we have more older patients than the rest of the country? Do we see more paediatric patients than the rest of the country? Where you see a bar and a dot, the bar will represent the national picture. The dot will represent whatever system or site that you have selected from here. So we can see that. What we can also show in the top right-hand corner, though, and thankfully this wasn't me that said this, but it was drawing out the fact that maybe the NHS and the way in which it's structured is the fact that it's institutionally ageist, because what we can see is that the bars, once again, are the England position. The dots are the particular site that I have selected. And here what we've got is the 10-year breakdown of each individual patient. We've then got the amount of time on average that a patient has spent in the department. And what we can see from this is that as the patient's age increases, so does the amount of time in hospital. And ironically enough, if you'd have asked me this a couple of months ago, I'd have given you the example of what if my 80-year-old mum, she turned 80 in April, what if my 80-year-old mum turned up in hospital? Then that's absolutely, that's not good, but what would happen to her and how long would she spend in the department? Now, what we can see is, we can see for this particular organisation that a patient who's 80 turns up and they're in a department for 1,000 minutes. Okay, that is a phenomenal amount of time and significantly above the national profile. But equally for a patient who's 20, and my son is 20, and they are in a department for 500 minutes. So we've got a 20-year-old and an 80-year-old, but there is a twofold variation in the amount of time that a patient spends in hospital. Now, the weird thing is because that story that I told you about, what if my 80-year-old mum turned up in hospital and what if my 20-year-old son, that has happened in the past 3 weeks. So I wasn't being prophetic in when I spoke about it, but it's been very, very interesting to see how life imitates art, because what I've experienced through the data, I absolutely saw in real life. Now, I know we can't directly compare and contrast a 20-year-old with an 80-year-old because of the comorbidities and the complexities, but should there be a twofold variation in the amount of time in the department based on age? I would argue not. But actually, it does come down to some of the frailty issues that we'll be talking about in a couple of minutes' time. We can equally see in the bottom left-hand corner around deprivation, and this is something which has been a really, really interesting area of observation over the past few weeks, where we've identified population coming from a more deprived area. So deprivation is split up into deciles, 1 being the most deprived, 10 being the least, where we see for some organisations a high level of their patient attendances coming from a more deprived area, but they potentially come into areas where they don't necessarily need a type 1 emergency department. I know a number of organisations are going through something called ATED at the moment, the Alternatives to the Emergency Department, because a type 1 emergency department is not for anybody and everyone. It is designed for seriously ill and injured patients, where we need to dedicate the amount of capacity that we need for that level of demand. Next slide, please, Joe. There's another area to have a look at, which is around frailty. Now, as I just talked about, the amount of population that fit into the category of 75 and old is increasing, and not only that, will continue to increase for the next 20 to 30 years. Data that comes out from ONS clearly demonstrates that this patients are living longer, but patients who historically may have not survived a catastrophic illness such as a stroke, acute MI, etc., patients are now living longer. But the challenges are that these patients are more complex, do have more health needs, will come to the emergency department and need admitted more frequently. But a tool that has just been created and it's been trialed with a few organisations is specifically looking around frailty and what happens to patients when they come into hospital. Now, a number of these products are not just a standalone product, i.e. you can click on your hospital and it will demonstrate what has happened in your hospital, but a number of them are scenario tools where you can factor in, what if I do X and what will that mean for my organisation? A number of them, the Frailty Opportunity Tool, the SEDIT, the Emergency Department Staffing Tool, and the Inpatient Bed Modelling that I'll be talking about later on, all have scenario plans in place that you can factor in some of your improvement objectives, what impact they will make, and how that will progress over the next 12 to 18 months. So it's really important that, yes, you understand where you are now, where you have been historically, but also the potential impacts of any improvement changes and how that will differ from your history going forward. Next slide, please, Joe. Also, what we've looked at, and through a number of these dashboards and products I'm going to show you, we look at things on an annual basis, a quarterly, a monthly, a weekly, a daily thing. But there's a couple of things in here that it's the real variation by time of day that is the really important thing to master. And one of the key areas that I kind of always highlight to people, and it's always a piece of data that we discuss a lot with organizations, and bizarrely enough, it's a really simple piece of data to A, obtain, and B, measure. It's the graph in the bottom left-hand corner. Now, for this particular organisation, they struggle with the time to treatment measure. So the time to treat measure is the proportion of patients seen within the first 60 minutes of arrival by a decision maker. And they are performing quite low. Only about 12% of their patients seen each day achieve that particular standard. But not only is that a challenge, but it's the time of day of arrival that is the real challenge for this organisation and a number of organisations across the country. So in the bottom left-hand corner, what we've got is the x-axis is the hour of the day, and the y-axis is the average number of minutes that it takes from arriving to being seen by a decision maker. And what we can see is for this particular organisation, which is highlighted in black, and the grey is the national position, is that if I turn up at 9 o'clock in the morning, on average, I'm going to be seen after around about 2 hours. And you might kind of say, okay, you know, I've waited 2 hours. I've still got another 2 hours to admit, treat, discharge the patient. That's not too bad. However, you can see the variation by time of day. So actually, when a patient arrives at 1 o'clock in the morning, on average, bear in mind, this is on average, they have already breached the 4-hour position before they've been seen by a decision maker. Massive, massive variation. But this clearly demonstrates there is an issue around flow and capacity. I'm going to be talking about different types of capacity at the latter stage of this presentation. The other way that we can have a look at it is levels of demand. Now, demand is quite an arbitrary measure, as in how many people turn up every hour, every day, every week, etc., etc. Does that vary by day? Yes, it does, for various different reasons. But actually, that is one way to look at demand. Another way to look at demand is how many patients you have in a department at any one time. So for this particular organisation, there is a huge difference in the way in which you measure demand, i.e., if they just had to look at how many people turn up every day, their year-on-year demand has reduced by 2.72%. But if you worked in an organisation and you covered midday or midnight, and you said to them, your demand is decreasing by nearly 3%, they'd laugh in your face. But that's where you need to kind of have that relationship that I talked about right at the beginning about marrying up anecdote and evidence. Because although the amount of patients that turn up at your department has decreased, the number of patients within your department has increased by 12.5% at midday and nearly 10% at midnight. So therefore, it's really interesting that we have a look at demand in both different ways. And we're going to be talking about this as we go through this session. Next slide, please, Joe. There are a number of different tools created by a sister team of ours called GIRFT, which is the Get It Right First Time team, headed up from the emergency department perspective by a guy called Chris Moulton. If you don't have access to these dashboards, as I've just been talking about, please let us know and we can make sure that everybody gets access to these. You do have to request them, but it's a very simple process in which you can request this. The vast majority of the data, both from the SAPIT and the SEDIT, come from different data submissions from organisations. So we don't necessarily need additional data from each individual organisation to be able to populate this. The vast majority of data comes from either ECDS, it can come from SUST, or it can come from a couple of other different submissions that are automatically done by each individual provider across the country. So it's not something that is specifically requested. The SEDIT takes data from these different sources and once again specifically focuses on the emergency department, but they do have different tools as I'm going to talk about next. But what it allows you to do is it allows you once again to put national context to this. And I'll just draw your attention to a couple of different slides. We're going to get hopefully going to get Chris Moulton to come along and talk at our next event. But what I want to just draw your attention to are the specific areas in this particular dashboard that enable you to look at where you are and where you need to be in order to be at the national median position. I know that might not make a lot of sense, but I'll just kind of talk about that. For this particular organisation, I'll just draw your attention to the third box at the top, which is workforce. Now, we've got ED consultants and we've got ED registered nurses, and you can see that there are two different numbers on here. So for the emergency department consultants, they have submitted that they have 5 whole-time equivalent consultants working that organisation. But you'll notice there is another number underneath that. So it's highlighted that 5 is slightly low based on the level of demand that comes through that emergency department. Therefore, in order to get to the national median position, they need an additional 2.06 whole-time equivalent workforce to get to the national median position based on the level of demand that that organisation has. So what this tool enables you to do is enables you to really quickly and clearly see where you are potentially short of capacity. Bear in mind, there's 2 different types of capacity, both physical and functional. But you can see from both consultants, registered nurses and ED majors, resus and cubicles, that this organisation is short of all of those, but also B, where they would need to get to in order to be the national median position for the correct level of demand coming through the front door. It's a fantastic tool, used an awful lot by organisations across the country, and we will be going through it in more detail as we go through the session. Next slide, please, Joe. The next one is the SEIT. Now, the SEIT, the Summary Emergency Ambulance Indicator Table, is a product which is contained within the SEDIT. Believe you me, there are a lot of acronyms, as I talked about right at the beginning. Even I get them wrong every now and then. So if you haven't seen this one before, it is embedded into the SEDIT dashboard and is available here. But whereas you are you've got the emergency department, and obviously ambulances is intrinsically linked to that. So what we've got is there are a number of different metrics around here: hear and treat, see and treat, convey, etc. And we've got all the different average category response times as well. What you'll notice is we've got where that organisation sits within the national picture, which is the third block of bars over on the right in the middle. We've then got trend lines to see how it's changed historically. But the one thing I do just kind of want to draw your attention to is around singular metrics. Now, we're going to be talking about this quite a lot in terms of the role of an analyst, because if, for example, I talk about length of stay, or I talk about see and convey rate to an emergency department, these are singular measures that need balancing measures to go on top of those. And length of stay is a great example of this. And I'll talk about length of stay and I'll talk about see and convey. Your length of stay could be going up, and that is not necessarily a bad thing. So I was challenged in my old organisation that our length of stay was continually going up, and our director of finance was really challenging us quite heavily on our length of stay. And I challenged him back to kind of say, is that a good thing or is it a bad thing? Because if you do more work to look at alternatives to emergency department, emission avoidance, if you're doing more work around SDEC, assessment areas, potentially the people that find their way to an acute bed are going to be very, very acutely unwell, and their length of stay, almost by default, will be significantly higher than an average patient. So we do need to take into account, yes, length of stay, but you'd also need to have a look at things such as your proportion of patients going through SDEC, your proportion of patients going through assessment. Same thing for this particular organisation around see and convey to the emergency department and conveyance rate. Now, this particular organisation has quite a high conveyance rate of 58% of all of their patients go through to from being assessed, having an ambulance sent to them, and going to the emergency department. But actually, the reason why we have that is because, once again, it's a singular metric. So if the hear and treat rate is low, you would expect the conveyance rate to be high, because they are intrinsically linked. You've got to take all of the individual metrics, but have a look at them in comparison to some of the other baseline and benchmarkable metrics contained within each of the dashboards. Next slide, please, Joe. The Summit is a very new dashboard. So this is the Summary Acute Medicine Indicator Table. So whereas the SAPIT looks at the whole system, the SEDIT looks at the emergency department specifically, the Summit focuses on the acute medical element of it. It's a very, very similar makeup, but it focuses on the type of patients that are going through to either your SDEC or your assessment areas, but it only focuses, I should stress, it only focuses on medicine. If, for example, you have a high functioning SAU, as an example, it does not take that into account, but there will be different products coming down the line to have a look at those individual particular areas. Once again, it does the same thing as well. So we've got different domains looking at demand, workforce, bedded capacity, and case mix. And for each of these areas, it will apply the national context, and if it is significantly low, will show you where you need to be in order to get to the national median position. You'll also notice a few different graphical representations on this particular slide as well, so we can have a look at what happens by time of day, by day of week, so that we can understand, as I talked about earlier, about the variation by in day, because that's the important thing. There's still an awful lot of organisations have an SDEC unit, and it's probably only open between certain hours. But the challenge is, do we know when those particular areas should be? And if we have them only open 8 till 5 or 8 till 8, well, actually, do you only take patients up till around about 6 o'clock, because then you're tailing off the amount of demand going through that unit? Or if it's a 24/7, do we need it open 24/7? What are the types of patients coming through our acute assessment areas, and the type of acuity? There are lots of different ways to have a look at acuity. There are a couple of ways in which we're going to have a look at it through here, but we're also going to have a look at them in greater detail, because they do require a little bit more explanation as we go through that. Next slide, please, Joe. The next dashboard that we're going to have a look at is the ECDS dashboard. So this is something which has been, once again, relatively new. It was launched the latter stages of last year. So the emergency care data set is a phenomenal amount of data, which comes from each emergency department on a daily basis. And there is a wealth. I cannot even begin to express how much data is contained within the ECDS submission. But just like the SAPIT and the SEDIT, these are not performance management tools. I think it's really important that we do stress that. I suppose the counterbalance to that is that we know what things are designed for and what they are used for can be very, very different. So our dashboards are predominantly designed to be improvement tools, but we do know that organizations use them as performance management tools. Just like all of the different products, each of the different areas within the ECDS dashboard, you are able to drill down to individual ICSs, STPs, providers, and department types. It's great that we now have these national products are now available to go down to each individual local area, because, you know, I imagine we've probably got individual people from acute providers, but we've also will have people from ICSs, from regions, so that we can have a single dashboard that people can drill down to the level of detail that they need to go down to. And the link in the dashboard is available on this particular site, and the way in which it's accessible is through the usual routes. But just a kind of a few slides around what the emergency care ECDS dashboard looks like, because I love a Sankey diagram. I know that makes me sound quite sad, but I think a Sankey diagram is absolutely brilliant way in which you can translate a flow across different pathways in a really nice visual way better than you could do from a normal table or even a graph, for example. So the Sankey diagram enables us to have a look at where the patients have come from, what happens to them once they have arrived to us, but then importantly about the different distribution channels to understand, as I was talking about earlier about frailty, what proportion of our patients go direct to a base ward, what proportion of our patients go to an SDEC, and now with SDEC being reported as a slightly different level of emergency department activity as a type 5, we can investigate this in far more detail. It's a brilliant addition to an already fantastically complex but comprehensive different piece of data. But what you can see, once again, as I just talked about, across the top banner, you can see that you are quite easily able to click on each of the individual component parts to select whether you want to have a look at a region, a system, a provider, or a site. And you can also have a look at different departure dates and arrival dates. So if, for example, you wanted to compare a pre-pandemic position with where you are now and whether different patients are coming from a different route, one thing that we have noticed is that a far higher percentage of patients are now bypassing the emergency department and going direct to an SDEC or an assessment area, which is great, but obviously does sometimes constrict flow coming out of the emergency department because you have so many patients going directly to the SDEC unit. But using a Sankey diagram, we'll be able to demonstrate how the patients flow through the system. Next slide, please, Jay. We can also have a look at acuity. Now, as I talked about, there's two main ways to have a look at acuity, but it's important that we understand the differences, but we also understand about how this has changed over time. So the way in which it's shown in ECDS slightly differs from a different couple of dashboards. It's shown by very urgent, urgent, standard, non-urgent, and unknown. And those categories are broadly linked to the different streams within the emergency department, i.e. minors, majors and resus. But patients could go to one of those areas because of that was the most appropriate place to receive a specific treatment, not because that was the place where they had to go. It could just be where capacity is. A different way to have a look at it is around HRGs. We haven't got time to go into that right now, but the two levels of acuity is really, really important to understand that actually the type of patients that come to your department who are acutely unwell and go through majors and resus actually doesn't vary significantly on a daily or monthly basis. What does vary massively, as we saw through the early stages of the pandemic, is actually the lower acuity patients. Once again, mapped, as I talked about earlier, about deprivation. So we've seen a massive higher increase of patients from a more deprived area attending a type 1 emergency department for lower acuity issues. And using data like this, once again, marries up the anecdote with the evidence to suggest ways in which you could potentially improve both demand coming through the front door and flow through the emergency department into an appropriate onward care setting. That may be discharged home, that may be discharged to a different care setting, or it may be discharged to a place within your acute provider. An area which is really, really overlooked and often is to blame for areas where you kind of discard certain things is around data quality. And I make no apologies for including the slide around data quality. And it is something, as I said, which is overlooked, but through the ECDS dashboard, you can quite easily and quickly view your data quality status, so that when you go through with organizations and you pick something, and I'll just pick something at random, the wait for a bed as an example, which is classified as the APD6 in the SEDIT dashboard. I'll just throw in another acronym for you. It's really important that we take a look at that. APD6 is a fantastic measure to have a look at the amount of time patients wait for a bed after a certain amount of time. But actually, the APD6 can only be calculated if the onward discharge destination setting within emergency department data set is collected. Now, you can quite clearly see on this particular organisation, on the bottom row, on the third measure, we have a look at discharge destination data, and we can clearly see that they have an issue around the completeness and or the quality of the amount of data coming through the ECDS submission for this particular area. So although APD6 is something that has been discussed by lots and lots of different teams to demonstrate onward care setting and some of the patient harm and clinical risk that can happen to patients, for this particular organisation, we couldn't do that because of the data quality. The thing that I will absolutely stress is data quality will not get better by itself. I can absolutely guarantee you around that. My advice, and where I've seen it published, done really well, is that data is published, even though you know the data quality is poor, because then it will drive improvement going forward. The way in which you access the ECDS dashboard is by using the analytical portal within NHS England. It's very easy to get access to it. It's produced on a business intelligence piece of software called Tableau, which I'm sure many of you will already have seen. We'll be sending out these slides, we'll be sending out the recording, and we'll also be sending out links to access all the different dashboards that we've gone through this particular topic. The last thing to just mention around ECDS is the same team that produced that also has a new dashboard coming very, very soon, hopefully mid-September, which is around same-day emergency care. So we're going to have a vast amount of data from the emergency floor perspective. And when I talk about the emergency floor, I mean both the emergency department and the SDEC and the assessment areas. It's going to be used in exactly the same way. We published on Tableau. Once this dashboard is published, hopefully, as I said, talked about mid-September, we will make sure that everybody has access to this, because this is going to be a phenomenal tool to help drive flow through the emergency floor. The last thing I want to talk about is demand and capacity modelling. So this is an area, once again, where organisations have looked at, and we get contacted an awful lot of time to kind of go through what is being asked of organisations. And you know, through the UEC recovery plan, there is kind of a requirement to have a look at how many beds you're going to need, how many people you need. And realistically, when I've done demand capacity planning in the past, is that people have gone down the route of overcomplication. So when you look at statistical modeling of any description, there's only really 3 things you need in order to cope with, in order to do any type of statistical modeling. And that is demand. How many patients do we expect to go through the service that we plan to offer? And that can vary by time of day, and it can also vary by day of week. Time, in terms of how long do patients spend with us? That could be in terms of a productivity of staffing, how many patients do we expect each staff member to see? Or if we were to have a look at something like bed modelling, it could be the amount of time that we plan that patients will spend on a bedded capacity with us in our particular bedded area. I should stress that could be a physical bed, i.e. within our hospital. It could also be a virtual bed. It could also be a bed of any description in a different care setting other than an acute provider. And then capacity. Now, I always kind of slightly joke when we talk about capacity, because the number of bed meetings I've been involved in where we discuss how many beds do we have, and you could have 10 people in the room and you would come up with 10 different numbers, which always baffles me because beds are pretty big. They don't hide in the cupboard. So actually we really should be able to understand both the amount of beds we have, the amount of escalation beds we could potentially have open, and the amount of staff that we have to cope with all of those beds. So Deming said that all models are wrong, but some are useful. So we kind of go down that route, and what we've done is we've created 2 different types of statistical model, which can help you to have a look at the 2 types of capacity. So the first type of capacity is around functional capacity. Now, the functional capacity model is mainly used for emergency department staffing. How many staff do we have on by time of day, by day of week, by the different types of staff grade? And most importantly, do we need to change those? So this model is very, very straightforward to populate. We can have this up and running in around about half an hour. And what it does is it looks at, once again, your demand coming through your front door. We can take into account your productivity of your staff and the type of staff you have on. And then the graph and the table are showing the same data in different ways. Some people like to see it numerically, some people like to see it visually. And if you have a look in the graph, what it will show you is when the bars are below the line, it's where there are not enough staff. When the bars are above the line, there is, quote unquote, enough staff / too much. Now, for this particular organisation, they challenged me to kind of say, we felt as though we needed more staff overnight. But once we put the model in here, once we put the data into the model, what it showed was actually they didn't necessarily need more staff overnight, because that was when the queue was kind of manifesting itself into its biggest kind of number. But actually, the queue started to form between the hours of 9 in the morning and 1 o'clock in the afternoon. But actually, the queue was just building and building and building and building. But because you had different services that were being offered, SDEC was open, assessment areas, you might have had more GPs at the front door as well, helping out with flow. It might not have felt that, but your queue time was just building and building and building. Once again, I said, this is a very, very simple model to update, can be populated within about 30 minutes to really drive that conversation going forward around, do I have enough staff on at the right time? And if not, what particular areas do I need to focus on? The other area around capacity is the physical model. So functional is around staff. Do I have enough staff in order to cope with the amount of demand coming through my front door? But the physical model looks at physical things such as beds, trolleys, chairs, cubicles, etc., etc. Now, what we've got here is we've got the EC bed model. It's been used in a number of organisations over the years. Once again, a very, very straightforward model that I created. The reason why I created it was because when I worked for an organisation, we did have an outside consultancy come in, and they didn't understand our system at all. So I thought, well, how difficult it is. I work with the 3 simple concepts: demand, time, and capacity. So what we've got is we've got the model in the bottom section of the slide, where we can see 2 different graphs and 2 different colors on those graphs, the blue line and the black line. The blue line will be the historic amount of demand coming through our front door. And over on the right-hand side, we've got the blue line being the historical length of stay. And the black line is using the historical data that we know, we've worked with, we understand it because we've been working with our analysts and our clinical and operational colleagues. But the black line will then forecast what we have observed from the historical data going forward for the next 12 to 18 months. And so because we've got the amount of patients, we've got the amount of time they're going to spend with us, we can then have a look at how many beds we need. Now, we can have a look at this in terms of how many beds does our whole system need, does our hospital, does our provider, but it can equally go down to different levels, such as how many beds do I need for trauma and orthopedics? And even so far as to kind of say, well, actually, how many beds do I need for trauma and orthopedics? But how many do I need for elective T&O? How many do I need for non-elective cardiology? It goes down to any level of detail because the fundamental principles do not change: demand, time, and capacity. And because we understand that, if we move on to the next slide, please, Joe, we can see where there are gaps. So for this particular organisation, they felt as though they had not enough medical beds, but more than enough surgical beds. So over on the left-hand side, we've got surgery. Over on the right-hand side, we've got medicine. But actually, when I took them through this model, we were able to demonstrate that, yes, you're right. Your anecdote suggests that you have historically been short of medical beds. The model predicts that you will be even in a worse position going forward over the next 12 to 18 months. But equally, with what's been going through in terms of surgery, we can see that your activity has been going up, your length of stay is going up. So where you've been able to potentially swing a ward from surgery to medicine to help cope with the winter demand, because of what's going on in surgery, in 12 months' time, not only will you be short of medical beds, but you'll be needing surgical beds as well. So I'm really conscious that I have done a whistle-stop tour of lots of different products, services, tools that are available to you. But during the next sessions that we're going to go through them in more detail, hopefully generate an awful lot of questions, debates, and if people do want either access to the products or they would like help with looking at emergency department staffing and or physical bed modelling, I'm more than happy to be able to assist with that. So I will hand over to Lisa for any comments or questions that people may have.
That's brilliant. Thank you so much, Chris. I think you've definitely given the whistle-stop tour there for sure and crammed an awful lot into a short space of time. So thank you very much for that. There are quite a few questions. We're not going to be able to get through them all today. But as I said at the beginning, for any that we don't get an opportunity to pose directly to Chris, we will make sure that they get answered and sent out in the transcript post the event for people. So there's been a few, Chris, around some of the technical stuff and how you access, but I think you've answered that anyway. And I have commented to say that there will be a list of all the different software sources that you've talked about today and how people access them. We've just had a few questions. I'm going to amalgamate them a little bit around pre-admission, pre-hospital data and access to that, and where do we have a look at that. And then there's also, I'm going to combine a really great question around, are there any plans to start measuring deconditioning and its impact on flow at a national level? So back to you for that one.
I think the phrase "cat meat pigeons" springs to mind, Lisa. The short answer is, I was going to say no, but actually I'll rephrase and say I don't know. So I am leading on a few different areas. That is not one that has come up. However, it is something that I think we should have a look at. I'm going to make a note of that and take that forward. So thank you very much for whoever raised that, and it's something we will take a look at. One of the areas, although not technically linked, I think it's linked in a way, is something that we are looking at, is around and quite pertinent actually with what's been coming out of the weekend, is around elective care waiting lists, and the fact that elective care and cancer waiting lists have deteriorated in performance significantly. And one of the hypotheses / anecdote has been that more patients are now coming to an emergency department who are on a waiting list waiting for an elective procedure than they historically have, because they're waiting so long. And that is a piece of work that we are looking to publish once we've gone through the QA of that particular area. just writing that question down.
That's brilliant. Thank you so much for that, Chris. So yeah, if you could, there are a few in there, Chris, but I think for next time, just sorry for sending out the information post the event. There's just some questions around pre-hospital data availability, anything around non-health, so more social care data as well, and accessibility for that. But I'll let you have a look at those. There is one question I did just want to pick up. It's from a colleague, Tom Kennedy. And the reason I want to pick this up is it's sort of linked to a similar question that we had in the taster session around partnership working on Friday. There's a few words to it, so I'm just going to read it through. But part of bridging the gap that you talked about, Chris, is about a fundamental issue around perspective. Historically, information has been used for performance management rather than building understanding. As a result, people are sceptical and often work at odds with methods of recording it. When there's a feeling about information being a beating stick, people always find a way to work the system, making the data less representative of the reality that we're trying to understand. How can we ensure that hierarchical powers, and this was a question that was asked about system working as well, hierarchical powers don't react before they understand what things really mean and what they might teach us? And there's a nice little quote in there from Matthew Said's Black Box Thinking around pilots have immunity as long as they report near misses, encouraging honesty, openness, and therefore learning. So any hints and tips for colleagues on that?
Yeah, absolutely, Lisa. So the one that I learned, and I'm pretty sure he's retired now, so I don't think he's going to be on this call, so I'm not going to embarrass him. But my old divisional director at the organisation I used to work for, used to often pose to me really, really generic questions. Now, the problem about posting a generic question about what's going on in terms of urgent emergency care is, well, good luck trying to answer it. The way in which we kind of counteract or counterbalance that was providing a kind of an exam question post. So, you know, when you go into an exam, you don't answer a generic question. Well, okay, sometimes you do, but a lot of them are blah, 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 you know, very, very specific points. So when we used to work with this particular person, we would ask for, what is the exam question? Because it's rarely, tell me what's going in terms of 4-hour performance. It will usually be around, I've got a hypothesis. I want you to prove this specific point, because if you provide a generic response, i.e. a data handler just chucks out loads and loads of data and goes, good luck trying to understand that, people will misinterpret it, or they will interpret it that shows what they want it to show. So actually taking a very, very specific question is the way forward, and then building up your layer of genericness. Pretty sure that's not a word, but you know what I mean. Really starting off with a granular level of detail and then building up to the right, does everybody agree with this approach? Equally, it's also about building up that relationship. Okay, the relationship that I had, and this is not unique, so please don't get me wrong, I've seen this in countless organizations across the country where I was a business partner. So a lot of analysts work as business partners. I worked as a business partner with the medical division. Therefore, I would be in all of their, we called them executive performance reviews. You'd go to all of the different management group meetings. So you understood and you built up a relationship between that triumvirate of the analytical people, the clinical people, and the operational people. Everybody knew what each other's roles were, how they could benefit from each other, and equally say a very, very specific answer to hopefully a very, very specific questions. It does not happen overnight, but that's certainly something that we'll be picking up in the wider session.
Okay, that's great. Thank you so much for that, Chris. Right, very conscious of time, and it's 3 o'clock. I'm sure we've all got other places that we need to be. So it just leaves me to thank Chris very much for the session that he's presented to us today. I found it very enjoyable. Hope you guys have too. Just a reminder for our UEC champions out there, the first core learning event launches tomorrow, and that is the core learning event Preparing for Your Improvement Journey. So colleagues in the Northwest and Northeast region session should have your invites to join that at 10 a.m. tomorrow. And then the third and final one of the taster sessions is due to take place on Wednesday, which is Principles of High Functioning Organisations. That's being delivered by Chris Morrow-Frost. So look forward to seeing some of you at those events for the rest of this week. And everybody else, thank you so much for joining us. Goodbye.